Então, meu nome é Annika, sou professora assistente na Universidade de Columbia, em Nova York. Tenho vários anos trabalhando aqui no Brasil, na área de saúde mental. Isso o que vou falar hoje é um projeto financiado pelo Instituto Nacional de Saúde Mental do meu país. E é um projeto de 4 anos que está acabando agora em maio. Então estamos ainda avaliando, mas vou apresentar os resultados preliminares, tá bom? Então, como vocês acho que sabem, globalmente, só 1 em 4 pessoas recebe tratamento adequado para a saúde mental. E em países de baixo renda, é menos ainda. E um dos motivos por isso é o que lá chamam the 17-year Odyssey, que dura um promédio de 17 anos para 14% da evidência pôr em prática. Desde o momento de ter o financiamento inicial até o momento de chegar à prática, é só um pouquinho que chega lá. Então, esse é um problema que temos na saúde mental, intervenções baseadas em evidências, mas chegar desde aí, aqui, há muito cambio, muita mudança durante este tempo. Por exemplo, a internet, que Milton Weinberg, que é o meu mentor, ele fez um projeto aqui no Brasil e começou antes da internet. E ao final do projeto, tudo tem mudado. Então foi uma intervenção muito interessante, um estudo muito interessante, mas ao final não foi muito aplicável. Então, quando falamos da ciência de implementação, é uma ciência para tentar reduzir esse tempo. Então, o primeiro tipo de ciência básica começa com ratões, rats, e pode chegar a bedside, que é poucos casos controlado. Pode chegar à prática, são estudos controlados, por exemplo, que sabemos, terapia interpessoal, que eu vou falar hoje, é um exemplo que tem sido demonstrado baixo circunstâncias controladas. Mas a ciência de implementação é levar o que sabemos pode funcionar no mundo real, não? E toda a complexidade do mundo, tá? Então, esse projeto que eu vou falar hoje é um projeto de ciência de implementação e complementa muito o estudo que fizeram aqui com Camila, com Marcelo e vocês, não sei se vocês estavam, mas esse estudo de IP, de aconselhamento interpessoal aqui no São Paulo, mostraram que se é aceitável, se é possível, mas baixo circunstâncias controladas. Agora, em Rio, o meu estudo é estudar como integrar a mesma intervenção, IP, aconselhamento interpessoal, numa cidade grande no Rio e ver como integrar tratamento de depressão em uma rede de cuidado primário. E minha área de expertise é tuberculose. Então, eu me foco em tuberculose, mas são poucos casos lá. Então, foi realmente, se capacitamos no cuidado primário, tratar depressão para tuberculose, também serve para qualquer outro. Não tem que ser tuberculose. Então, foi uma doble enfoque lá. Então, vou falar um pouquinho da teoria que eu usei para desenhar o estudo, que começa com a ideia de difusão de inovação. que é uma teoria que começou nos anos 60 lá nos Estados Unidos. Começou isso geralmente é aplicado mais a como a ideia de como how to get, vocês entendem inglês? Posso me misturar? How to get a product to catch on, you know, if there's a new cell phone or something, or Facebook, when Facebook started, for people to start using it, or to do smartphones, for example. It's the study of how things spread. And so in mental health, it's the idea of how can we get evidence-based practices to spread in a network of services. And so this diffusion of innovations theory is this idea of the passive adoption when people do the intervention, as well as the passive diffusion, right? It's sort of an observation of how things spread. In implementation science, the idea is how can we do this actively? How can we make things spread? How can we intervene with active strategies to introduce new practices in new places? And how can we actively disseminate these interventions? So the hypothesis of my study, I wanted to do this in Portuguese, but it's easier in English. Is that okay? Entende? Sim? Desculpa. Okay. The hypothesis, so if you're going to enter into a system of care and introduce an intervention, you have to start somewhere. You can't do the whole network at the same time. Or, you know. So normally, in general, you pick a place that's going to be very receptive. Thinks depression is a problem, that doesn't have a crazy workload, that they're interested in learning. And so you find a place that's most likely to succeed in terms of adoption. And the level, the second level of theory that my hypothesis was also taking from this science of diffusion of innovations, that connectivity might help expand the diffusion. So connectivity is the degree to which people are connected to each other and have influence over one another. So the idea is not just to choose places that are most receptive, but also choose places that have the most influence over others, to spread the word that this is an intervention that works, that's interesting, and people can sort of look from afar and get excited about it. And so that was the idea. So the question is, by strategically selecting primary care centers, so SAFs, with the highest receptivity and the highest connectivity, can we accelerate scale up of an evidence-based intervention? So the study took place in Itaboraí, right outside the city of Rio de Janeiro. And we started with a pre-pilot in 2015, before the study that I'm going to talk about, where we did a community mapping exercise of looking at what are the mental health services available in the city, where are they delivered, and by whom. And we use mobile phones to do this. And we mapped out 50 facilities in the city, and the red dots are where there was any mental health provider. And you'll notice that there were over 50 providers, specialists in mental health, but most of them are right there in the center, which means it's not as accessible to most of the population. And in fact, only one specialist was in one of the ASAFs. So this is sort of a justification for, how the need to introduce services in.
You said 50 or 15?
50. There were 55, I think. Mm-hmm. So there were a lot of specialists in the public sector, but they were all in the psychiatric hospital, in the CAPS, in the ambulatory care, in the hospital, but all in the center of the city. And mostly for severe mental illness. So when the study began, the idea was to look to identify public health settings with the most connectivity and receptivity. Receptivity was measured based on 7 scales. Mental health literacy, so again, the degree to which they recognize mental health as a problem, as something That is, there's a need to recognize sort of self-efficacy, the degree to which someone, if you were trained in an evidence-based practice, what's the likelihood, what kind of confidence do you have that you'd be able to do it, readiness for change, attitudes towards evidence-based practices, etc. And connectivity was measured by with whom, and this was a focus on tuberculosis, with whom do you discuss difficult TB cases? With whom, so discuss is a bilateral thing, give advice to is a directional thing, and receive advice from. So that based on these data, I interviewed 163 people. These were identified initially from the head of the TB program and the heads of each facility, and then people that they would identify through Snowball that were experts in TB or people with specialized knowledge. And so this was the sample, 163 people, mostly nurses? Okay, so more nurses and community health workers, and then a sampling of other professionals. And through this process, was able to identify 2 health facilities that were the most connected in terms of having the most connections to others in the city. And interestingly, you know, these places, both of them are somewhat removed from the center of the city, and they both kind of had the reaction of like, really? You're gonna start here? They're just not the ones that you would ordinarily start with in a regular trial. You'd start in the center, you know, with the ones that are most organized. These are small, precarious health centers in the periphery of the city, which makes it really interesting in the application. So the first step was to adapt interpersonal counseling for the local setting. And we did 6 focus groups with primary care workers, so from those 2 health centers, as well as just in general from the TB program, and TB patients, as well as coordinators of programs. And the implementation questions are, you know, who should deliver the intervention, where should it be in the home, should it be in the clinic, how frequently, should it be group, should it be individual, or even do you think they'll prefer medications or a talk-based therapy, you know, what are the barriers, facilitators, so all of these questions. And this is part of a implementation science sort of exercise of balancing fit and fidelity. So you want to make it fit the application of IPC to the local setting to make it as appropriate and feasible and, you know, the most likely to succeed in a local setting, but still making sure that you're faithful to the original intervention, that the components, the core components don't change. So it can look different in different settings, but it's definitely still the same intervention. So the theory that guided this evaluation process is called the Consolidated Framework for Implementation Research. And I saw this in your proposal, right? So the idea behind this theory is that in terms of implementation, there's 5 factors that influence the success of an intervention, of the implementation process. So characteristics of the intervention itself, where did it come from? What's the evidence that it works? What is the advantage of this intervention above others? How adaptable is that intervention? How easy is it to trial and test? How complex is the intervention? The quality of the design and the cost. So these are all factors that influence the implementation. Inner setting is, you know, for example, in this case, the intervention is IPC. The inner setting is the clinic or the place in which it's implemented. So what are the structural characteristics of the center in which it will be implemented? What's the communication style and network of the context, the culture and the climate of the workers within a setting. These are the inner setting factors. The outer setting factors are sort of more policy, city, just in general needs of the population. Some of these terms don't apply directly. Cosmopolitanism, which refers to the degree to which networks of the system of care is networked to each other. influence and policies and incentives. The individuals involved are, on the one hand, the providers, and on the other hand, the patients. So knowledges and beliefs about the intervention, self-efficacy, as I mentioned before, readiness for change, attitude, identification with the organization, and other attributes of the individuals themselves. Are the individuals motivated to do this intervention? Do they have a background in this? Do they have preconceived notions, or that, with a lot of stigma, for example? So all these individual factors, or at the patient level as well. Are they going to come to the health center? Do they trust the health system? So these are individual factors. And then the way in which the project is implemented, obviously, is also going to affect it. So the way in which the planning happens, the way in which stakeholders are engaged, if you go in and implement wrong without having all the right players, it can fail. The intervention could fail, but not because the intervention doesn't work, but because it wasn't implemented in the right way. And the example I like to give here is, doing a group therapy in an African context where gender is important. If you have a mixed group intervention, that might not work for the women, for example, in that group. It doesn't mean that the intervention couldn't work for women, but not separating the genders in groups would be a critical implementation failure that could lead to perceiving that it doesn't work, but it really actually could be implementation. So in this case, as I mentioned, in this case it's the IPCs, the intervention, the setting are the clinics and the TB program. The outer setting is Itaboraí, the city of about 240,000 people. The individuals are the providers, as well as the patients, and the process is this pilot. And you'll see, I'm going to go through this in detail, but the facilitators are the green ones, and the potential barriers are the yellow ones. So let's start with the intervention itself. IPC is recognized by WHO as there's a strong global evidence of it, so there was acceptability in terms of the evidence base. And this is based on the focus groups. It was perceived to be, the idea of being close to the communities was perceived as an advantage, and there was a great demand for more training and capacity in mental health. The fact that the intervention could be adapted in a number of ways was an appealing factor. The cost is relatively low since it's based on task shifting, so it's non-specialists delivering the intervention. And the complexity of the intervention was perceived as acceptable because it's consistent with the model in Brazil of task shifting in general, and so it seemed a compatible fit. And so when you look at the end, actually there were no potential barriers, which is really interesting, which I didn't perceive that until I did this graphing. And you look here and you see, and I was like, oh wait, that's entirely green. How interesting. So there were no perceived barriers to the intervention itself. In terms of the inner context, there was high receptivity and perceived need. And this was actually a surprise to me because the context of Itaboraí at that moment, this is where Petrobras in Comperji is located, so 30,000 people lost their jobs overnight. The focus groups happened immediately after the president was impeached. People hadn't received salary for 5 months in the health sector. There were 4 changes in the Secretary of Health over the course of a year. I mean, it just was a very, very tricky moment in the city. There was the effect of the World Cup and the Olympics, where a lot of the drug dealers got pushed out, and so the violence and drugs went up in the city. It was a very complex moment, and for a moment I was a little apprehensive about bringing this new intervention to a setting that's really clearly overwhelmed. And to the contrary, there was so much enthusiasm. It was really humbling. They were really, we need this, this is such a big problem, there's so much unemployment, there's so much violence, there's so much depression, we need this. So that was exciting. There was compatibility, there was acceptability of the idea of this intervention within the setting. The trust of the community health workers with the community was seen as a real strength, potentially, that they have entree into these communities. So even though there's a lot of violence, the community health workers are known to the community and they're able to actually move around the community, whereas outsiders might not be able to. And the teams, the model of the Brazilian system, there was a probably not all the time, but this idea of very close teams. At the same time, there was way too few providers. Most of the teams don't have an entire team, and so they're very overwhelmed. There's very frequent movement of the professionals, particularly at the nurse and doctor level. So that's, thinking towards the future. If you train in one setting and then the nurses and doctors move, then you have to train again. So also this is sort of starting to think about community health workers versus other professionals. In these remote settings, they did not have access to medications. And one of them, they said, if we had them here, we would get robbed, because the misconception of antidepressants as like a controlled substance like benzodiazepines, which would be something that maybe they'd want to steal, but the idea of the misconception could lead to, they'd be too vulnerable, so they don't have access to medications in this health center. There was very poor referral infrastructure, so the CAPS, and these specialized services exist, but really referral just, it happens, they're like refer to avoid, they can make the referral, but often the person never gets services. Either they can't get to the center because the transportation or the cost, or even when they get there, there's a waiting list, or, there's other barriers, and so, there's this gap in the infrastructure. There's very low mental health awareness. I mean, even the doctors and nurses were mixing up antidepressant with benzodiazepines, and the way in which they were talking about mental illness was very clear that they didn't have a very strong understanding. There's a sense of lack of control in the setting, and one very, very important point is that there's an extremely high rate of distress and burnout in the primary care, in the health network itself, because it's so overburdened. And interestingly, in the 6 focus groups, or in the 5 that were with professionals, in every single one of them, people were crying. And it was very interesting because these were not personal questions. This was, is depression a problem in your community? Would this intervention be acceptable? And the health workers themselves were saying, I need this, we need this. So that was a really important implementation point to bear in mind in the future. And there's very limited access to information and resources, perceived access. And they hadn't received salaries for 5 months. So in the setting of the city, there was a lot of violence, poverty, unemployment, substance use. There was concerns about storing the medications due to risk of theft. The task shifting on the positive side was consistent with the model of the country program, but it was a moment of acute crisis politically and economically, a lot of volatility and a lot of violence, and a lot of they talked about the violence even affecting themselves. Oh, I was just robbed last week. Someone broke into my house. I mean, this was very personal. And in thinking about, well, I'll get to that. So it was an overburdened and under-resourced system. There was very poor referral, and just the overall infrastructure was very poor. There were no phones in any of the health centers. Mobile phone connection depends on the setting. There's no internet in any of the facilities, so some people have it on their phone a little bit, but it depends. The transportation network was not very good. So all of these were the outer setting barriers. There's a lot of stigma about mental illness, and then the idea of depression and tuberculosis as 2 stigmatized conditions. And there was one person said they were concerned that potentially religious leaders might discourage people from even going for mental health services, so in the church setting, for example. Individuals, there was people talked about a big need, but that they have absolutely no training and they don't feel capable of doing it, but they really want the training. there was very poor knowledge about mental health, especially the use of psychotropic medications, which was evidenced in the way they were talking about them, and high stigma at the health facility level as well as at the community level. High distress and burnout, which is very important in the context of mental health, because if people are not feeling well themselves, it's very hard to ask them to help someone else, especially if they're experiencing similar problems. So this is a very important barrier to bear in mind. In terms of implementation, the questions about medications versus talk therapy, about group versus individual, about would it be acceptable for it to be a community health worker, or does it have to be a nurse or doctor? Would you trust, that? And pretty much every answer was, it depends. It depends on the provider, it depends on the person. Would they prefer group or individual? Would they prefer medications? And so really this is patient-centered care. So it's not a surprise, but it's important to take into account that it's going to vary in a population what would work best for anyone. And supervision was perceived as a very big problem in this context, because the two supervisors that are part of the research study that were going to provide the on-site weekly supervision, for them to get to these health centers, it's not safe for them to go by themselves. The only way they can get there is in a municipality car. It's not always possible to have the car. In one of the settings, it was perceived to be so violent and unsafe that it wouldn't be safe for them to go more than once a month. So the idea was, well, let's try to do it remotely 3 times a month, and go in person once. And as I'll get to, in that setting, the implementation did not work. It ended up just not happening, because we just couldn't supervise effectively. And engaging, one of the things that people said is that we really need to be trained as a team, that's very important, that whole teams have this understanding of the intervention and sensitivity to implementation. The community health workers play a critical role, and that this rotation of staff is potentially going to be a challenge. So the pilot began in 2018. We trained, Camila was one of the trainers, 33 people. So basically from these 2 health centers and the TB program, anyone who wanted the training, it was optional, anyone could participate. And honestly, I anticipated only a few people, because people are overwhelmed, and everyone wanted it. So from the administrators to the doctors, everyone wanted the training. So we had 33 people. More than half or around half were community health workers, but there were nurses, doctors, technicos, administrator, a social worker, a psychologist. In the doctor category, there were a couple psychiatrists, and the psychologists, those were people that were not in those health centers necessarily, but they were recruited as potential supervisors in the future. So thinking towards what happens when the research ends. So during the course of the year, there were, in 2 settings, the implementation was very successful. They had 39 and 37 supervisions in person, or mostly in person, and then a few remotely, after there was sort of a relationship and trust established. When they couldn't go there, sometimes they would do it over WhatsApp or over Skype. But in the other setting, it just never got off the ground, and they just said, we're overwhelmed, we can't do it. We don't want to do it. And because this is a implementation trial, that's a very valid outcome. So it wasn't that the trial was a failure, it was that the reality is that the setting is very difficult, and it might not work in the same way in different settings. So the dissemination activities, again, trying to actively diffuse best practices. Once a year, we had half-day seminars on TB and depression in September of every year. And we had very big turnout, 100 people coming to these. Maybe the first year was like 60, and then the participation went up every time. Anyone in the health network was invited to participate. The Secretary of Health was always there. He was very supportive, once we had a consistent one. And then every 6 months, or once a year, there's the TB, International TB Day. So September and March were the 2 times that we always reported back to the community on, progress of the study and what's going on. And we had Camila came in person a couple times, and then she also did remotely one of the times. I think it's Bernard, right? And in the last 2 ones, we prioritized people who were implementers in these health settings giving their own testimonies. So in this case, these are community health workers who were the implementers in one of the settings. The people from the TB program also told their stories. And so the idea was for them to share their own experiences. And if we have time and I can connect to the internet, I can give you a very short video of actually those 3 of those people giving their own testimony. So then the study ended, the pilot of 1 year ended. We did a training of trainers, of anyone in those 3 settings that wanted, or any of the 2 settings that we're implementing, to get more training to be able to disseminate the intervention. We also trained there was a few people who were really the champions in the implementation, the most successful implementers from each site, and those people were trained in how to supervise. That was 5 people. And then in June, the last active activity of the research was to support them, those trainees, to deliver their own first training. So they trained, so this is the head of the TB program, this is the doctor from the TB program, there was also a social worker and another nurse that they did the entire training, and then we supported them. So the supervisors who were going weekly, they were in the room with them, providing support, but not giving the training. And they chose the trainees. It was their choice who they wanted to disseminate to, and so it was a mix of people that they chose that they wanted to train, 17 people. And then now we're getting to the current stuff, so where the analysis is ongoing. The last focus group was last week, and the week before were the 2 patient ones, but I'm going to give you some preliminary outcomes. There were 7 groups with 38 people from the health centers and the implementation sites, including the one that did not implement, health coordinators and patients who received IPE in both of the settings. So in one setting, they're TB patients, and in the other setting, they're non-TB patients, because actually during the entire pilot, they didn't have any TB patients, so they were just implementing among people with depression in general. And sort of as higher level impressions and analysis of the outcomes is that when looking at, so this is from the perspective of health providers and coordinators. One of the barriers was sustainability and the cost of supervision. The fact that having those 2 people go to these centers every week was that's not sustainable. It's costly to hire them and then to get them, and it's a whole day just to do these 2 centers. So this is a real barrier moving forward. That's not a sustainable model, that we need to problem solve around it. The intervention was very. They loved it. They're actually, I should have reported here, they're actually still implementing in both sites on their own, and they don't have the support and supervision of the project anymore, but they're doing peer supervision. They're supervising each other, which is interesting. It's pretty cool, but one of the things that they said a challenge is that they're experts now in this intervention, but they're not mental health specialists, so they're really missing that element of additional supervision. So that's a challenge. The PHQ-9, which was used as a screening tool, turned out to be a really effective referral tool. So they would do the screening, and then the NASFI, they had a psychologist, when they did referrals for cases that were more severe, they could give the PHQ-9 and say these are the symptoms of the person, and that this really facilitated the referral process. So they saw this tool not just as a screening tool useful, but it was very useful as a referral tool. the distress and turnover and lack of staff, these were all continued to be challenges. The facilitators were the high demand, and in the one-to-one peer supervision that's happening now. In the outer setting, the violence, so I don't know if you follow the news in Taborai, that now that the militia took over and wiped out the drug dealers in charge, and so it's a different kind of violence, but it's perceived as less because there's no more a fight between them. So they're like, it's better now, it's less violence, but it's still the militia in charge. They're no longer...
No way out.
It's better. The mechanism, the referral also improves. So what I mentioned just about the referring to the NASFI, also the TB program and the mental health program that are both centrally located, that referral mechanism became a lot stronger. So for the more severe cases, still a moment of acute crisis, but they were receiving salary, so that was no longer a barrier. Let's see, there was more confidence, there's still a lot of burnout. Even in the site where they didn't implement, they reported that since the training that there was a change. They have more empathy, they listen better. This is like anyone who received the training, that there was a change in the way that they see their patients and interact with their patients. So it's not IP, but it's a change. Which was interesting, and we saw the same in Sapopemba. We were there yesterday, which I'll mention. And one of the main challenges was the fact that the mental health program was not involved. And this was not for a lack of trying. We tried at every step to involve them. There's personalities involved. The head of the program was about to retire and just was non-responsive, and so it was not possible to engage them. And so when we interviewed the people who had done their own training and that were still implementing, they were saying, we really need we need the support of the mental health program, and that was really a gap. And their mental health program, actually, some of them participated in the new training, so now they're interested. Now that it's happening, they're like, oh, actually, that could be interesting. But that didn't happen initially. And what was it? I was going to say something else about that. Okay. So from the patient perspective, the PHQ-9 was sometimes hard, especially for the TB patients, for them to understand the questions, particularly because TB symptoms and depression symptoms are overlapping. So appetite and fatigue and sleep, all of these are depression symptoms, but they're also symptoms of TB, and so it's sometimes difficult for them to know which are they, But in the other sites, they didn't have as much problem with it. So and then there's just a few. One of the patients was referred to CAPS. Nothing happened. They weren't seen. They came back to the clinic, and then they received IPC in the clinic, and that was successful. People that got better, people in the community were asking for service. So we actually remember in the TB program with one of the first cases got better right away, and then the pastor from that person's church came and said, like, what did you do? How did you, can we get this? Can I get this? Can our community get this? Just, huge demand, and seeing this, seeing the change, seeing effect in a few sessions was really remarkable. And there's, again, a high demand at the patient level. And so I talked about these. So overall summary of findings is that IPC was acceptable and feasible, that people of all levels, professionals of all levels were able to learn. So, and this comes down to the other implementation question, which is going to be the focus of all of our next studies, which is how do you work in a system of care when you have people with different levels of motivation, when you have different, to do IPC, you have to have a certain perfil, you have to have a certain personality type and interest to do it. So, much like the Sapopemba trial, we trained everyone, but only a few people implemented. That said, they saw it as a huge strength that the whole team was trained because everyone was sensitized to the intervention. And then the people who implemented they chose themselves. So that was interesting. And then in Sapopemba, that came up too yesterday, where one of the community health workers during the trial was saying that she got, people were saying like, oh, you think you're, she got bullied a little bit, like, oh, you think you're a psychologist now. Like the fact that the other people in the center didn't know what they were doing was a barrier, was a problem for her to be able to even implement. The distress in health workers is significant. The need among health workers themselves, and possibly some of the people, who might have implemented, didn't implement because they were struggling with depression themselves. And this came up again in Sapopemba yesterday, that like, if you're going to do a training, you have to start with us. We need the services first. And we learned that in-person supervision is costly and not sustainable, and remote supervision is possible, but in this case, it really required there to be a relationship and trust between the supervisors and the teams for them to be like, okay, yeah, let's do over WhatsApp today, Once there was trust, then that did work, but when there was no relationship, and then we have, the sample sizes too, but that was an observation that might potentially be replicated. And so what are the next steps? So again, we still have this question of, on a larger scale, and I'm still analyzing the receptivity and connectivity data, and so we'll see what happens with that piece. If the people who were connected to the implementers had an increase in receptivity. The potential challenge I'm going to see, that I'm anticipating with that, is that the overall receptivity at baseline was so high, which was unexpected, that it might be hard to see change, but we're going to look at that question. So these questions are, how can we train an entire network? Can using integrated blended methods of training, using technology, can that improve not only the effectiveness of training in terms of knowledge and attitude, and in particular, importantly, the behavior change aspect, as well as cost and sustainability, and how can we use evidence-based training methods to teach? And I'll go through each of those very quickly. So I have a proposal that I submitted last year that I'm resubmitting in June, but it looks at these questions. And one of the hypotheses is, so we have this whole field of education about how people learn, how people process information, how people retain information. There's all of this evidence and knowledge that we have about the best way that people learn. And in particular, adult learning is different from just teaching in general, pedagogy, which is the children or anyone, and then andragogy is adults. And one of the key elements of that is that adults need to know why they're learning something. It has to be more relevant to their prior experience. There's certain elements that need to be present for people to engage with the material for teaching adults. And so one of my hypotheses is that enhancing learner choice, instead of doing it everyone gets the same training, having a little bit of choice of for the people who are more motivated to be able to get as much training as they want, and the people who are less motivated to just get the basic training to try to improve awareness, reduce stigma, just the basics, to screening, or at least identifying someone who might need to be screened, for the people who are less motivated, and then so sort of taking advantage of that spectrum of motivation and helping, and that I suspect will help us to identify the champions in the community, who might be the doctors, nurses, or the community health workers. It might be any different profession, but they'll identify themselves essentially, and to encourage that and foster that, I suspect will be a way to improve that. So the blended training approach, the way that looks, and that's applying the evidence-based principle of the fact that the typical training is this intensive training followed by supervision. So intensive 3-day training, for example, which is what I did in Itaboraí, which is what you did in Sapopemba, followed by the weekly supervision. It works, it can work, but it took a long time to get started, in large part, I suspect, because the training was, they loved it. Oh, I see things differently now. That was great. Thank you so much. But I suspect there was almost no behavior change immediately, and it took practice, and it took the weeks of supervision for them to get the confidence to be able to do anything. And so the idea, so that's one idea, is we know that giving everyone all the information at one time is not the way that people retain information. It doesn't have the time to go, it stays in the working memory and it doesn't go, deeper. And so one of the principles is spacing out learning. So the idea of having, in-person training, so this doesn't replace in-person training. In-person training where it's practice and, very practice-oriented, and then learning and then practice and then learning and then practicing and learning. And this is, the way that social work is. I don't know about other disciplines, but I'm a social worker, and that's how social work education is. The first year of the master's is 2 days in the field, 3 days in the classroom, and the second year is 3 days in the field, 2 days in the classroom. And I found that to be a very effective model for learning. You see something, you bring it to the classroom and ask questions, and so it's that model which is being adopted more and more in universities, and it's also called the flipped classroom, and the idea of getting the didactics online or in advance, and then coming into classroom and having it fully interactive and not a passive lecture. You get the lectures online, but in class it's interactive. So my hypothesis is that compared to training as usual, that we can improve effectiveness, not just in knowledge and attitudes, but in behavior change, in cost, because of the lower resources in order to do this, to do it online and have these elements, and in terms of sustainability, because there's ways in which the technology can also support further implementation in terms of forums. People can ask questions to one another, and there's sort of a network of people who could, if we foster that, those connections could potentially improve the sustainability. And so some of the evidence-based practices that I mentioned were adult learners respond more to intrinsic motivators than extrinsic. And we asked this yesterday again in Sapopemba. I'm doing a few focus groups, so we did one yesterday and we'll do a couple next week, or in 2 weeks in Taborai. And the questions are really about acceptability, feasibility of this blended approach. So do people have phones? Would they use them? Is it, would they do things, would they study on their own time, or is that, how much material could we give them on a given week that would be realistic? Could it be 20 minutes? Would it be an hour? How much is realistic? They were saying 10 to 20 minutes. So it's really learner.
They said 5 minutes, 10 minutes video.
Well, I said one or two, and they said maybe 1 or 2. So I took that to be 20 minutes max. Hoping for a little extra time. Anyway, these are some of the evidence-based principles that I intend to implement in the context. These are the acknowledgements.